Hello, everyone. Guess what? We are back to another edition of Surviving and Thriving in a Pandemic. Today, we're talking about emergency rooms. We're talking about urgent care, and we're talking about primary care. Which one should we be going to, and when should we not go to the other? Did you know there's an average of a 286-minute wait in the emergency room? That's an average. But guess what? Sometimes we're abusing that privilege of using that emergency room, and so that can extend our time. We're going to talk more about that with our guest today. So our guest today is Mary. She's celebrating actually her 27th wedding anniversary in October. She was born and raised in Germany, and she moved to the United States in July of 2000. And guess what? She met her husband. He's here from Decatur, and he graduated from the Southwest Decatur. And they also have three beautiful children. The oldest is a softball pitcher at Savannah State. Their son graduated from high school and is currently working with the UPS, and their youngest daughter is a freshman in high school. She has a passion for emergency nursing and more so for this community, which is Southwest Decatur. She started working at Emory Healthcare, formerly DeKalb Medical, in 2011 as a patient care technician in the emergency department. She then transitioned into a staff nurse in 2012. In 2014, she became the charge nurse, later the assistant nurse manager, and now she is the unit director. She has worked outside of Emory Healthcare on PRN basis, but has always been full-time an employee for Emory. Please welcome to our show, Mrs. Eva Williams. She is a unit director here at our Emory Hillendale, right down the street from us. We welcome you to the show today.
Well, thank you so much for having me. I'm so excited, honestly. So thank you for the opportunity.
Oh my goodness, yes. And this subject that we have today, it is major. Oh my goodness. First of all, we're still in a pandemic, right?
Absolutely. We're
Okay.
still in the midst of a pandemic, yes.
Okay, so contrary to what people believe, we're still in the pandemic, y'all. We're still in it, okay? So that even compounds what we're talking about when we're talking about the emergency room and what emergencies are. So today we're talking about emergency rooms, urgent care, and primary care. Large subjects. But let's just start with emergency room. Let's just go there. Let's go there. I read that an average wait time is 286 minutes in emergency room. What's happening? Why are we waiting so long? What can we do?
That is an excellent question. I wish I would have the magic answer why there is such a long wait. A long wait specifically for our emergency department often is that our volume is way higher than what we actually can accommodate and how many people we can room in the back. And often there is a huge misconception as to what's really going on behind the scenes versus outside in front in the waiting room. So just a little bit detail about specifically about our hospital and our emergency department a little bit. So maybe that explains some of the questions people may have. So overall, our hospital here is actually licensed for 100 inpatient beds. Our emergency department only has 25 beds. That is considerably small when we talk about volume. Emory Hillendale Emergency Department has historically seen around 67,000 patients a year. And this is not patients that are admitted, that's actually patients coming through our doors here in the emergency department.
Wow.
So you guys kind of do the math. It's a huge volume. Usually on an average, it may be anywhere between 160 to 180 patients a day, sometimes more, sometimes less. And all of this volume has to be channeled through 25 rooms. Wow. We have various areas here in our emergency department. Areas where we see more critical patients. Of course, those areas often move slower because, patients need excessive workup and that takes its time. And then we have two other areas where we see lesser acute patients that we can funnel patients through a little bit faster and get them in and out. And so, yes, that's that's the whole craziness in a nutshell. So,
wow. So
yes.
Like you said, that volume, 25 beds and 167 people coming in. Yeah.
Yes.
So if we did the math, It's going to be a while, folks. It's going to be a while.
It is a while. And now what you have to consider, speaking about the pandemic, is
yes.
hospitals are full. So let's talk
Yes.
about specifically about the pandemic and
yes.
issues that occur everywhere in every hospital. That is not the exception. We're not the exception. That's currently
Yes.
every hospital in the U.S. So we are in the midst of a pandemic. We have extremely sick patients. The patients are sicker than they have ever been before. And so many of them require hospital admission. So again, if you think about, we see a high volume, we only have 100 beds. So once these beds are filled, there is no way for these patients to go. So they often stay in our emergency department days at a time. So you have to now deduct those beds from the volume that we're still getting through the front door, but we can't move because our inpatients are with us down here. So that limits us even more. So, and of course that will increase the wait time for everyone else.
And I wanted to preface by saying that we're still in a pandemic because I think we see people moving about in the world and we're doing a little bit more. But the fact is our hospitals are still inundated with COVID-19 patients that are coming in, and then the regular emergencies that are happening or non-emergencies that are coming through your doors as well. So I did want to just highlight that there's so much happening. So we're at home though, and we're having what we believe is an emergency. What constitutes an emergency? What do I absolutely need to go to emergency for?
Of course, the number one thing, there's two things that come to mind. I mean, there are many, but of course, unexplained sudden onset of chest pain that can be radiating anywhere to your arm, to your jaw. Women tend to show different signs than men. They're not quite as obvious. They sometimes have abdominal pain. So for women 50 and older, yes, that would be also an indication. If you all of a sudden are in severe pain, you're sweaty, nothing can control the pain, of course. We're still talking about chest pain. You're becoming very nauseous. That's definitely an emergency, and you need to come to the emergency department. Signs of a stroke. You all of a sudden have onset of facial numbness. You becoming disoriented. One of your or two of your extremities feel weak. Things of that nature. Definitely an emergency. That's a timely thing, and people should come in as quickly as possible. What else? There are many things. Again, severe abdominal pain, of course. That could be many reasons as to why there is severe abdominal pain. That's definitely an emergency most of the times as well. So those are the top three that I can think of.
Okay. And of course, COVID-19, if someone's diagnosed with COVID-19, and when do they need to come into the doctor? When do they need to possibly come to emergency?
That's a great question. I should have added that, of course, to my other emergencies. Respiratory distress. So that is very important. So as we all know, there are people that are testing positive for COVID. They don't have any symptoms whatsoever. Please do not come to the emergency department. There's absolutely no need, if you're feeling fine, to come to the emergency department. But if you becoming increasingly short of breath, that you just feel like, it's getting worse, don't wait too long. If you really have the sudden onset of short, you need to come to the emergency department. So those are all things. High fever that can't be controlled, need to come to the emergency department. But of course, the second you feel like, okay, I'm really short of breath, that's definitely an indication to come to the emergency department.
Okay.
And the sooner, the better.
Yes, I believe it.
Because I know a lot of people are still hesitant to come and they want to toughen it out, but that toughen it out sometimes can have bad outcomes, as we know. So I would definitely encourage people that feel short of breath to come.
Have you seen more people now trying to do wills and estate planning now that we've gone through it, are still going through the COVID-19 phase of our lives?
I've seen a lot more people trying to do that. to have wills, to have healthcare directives, to even to the point of having living trust. For example, a will goes through probate, so it's public knowledge. But trusts are not public knowledge, so families are really starting to take a hard look at what if I'm incapacitated.
Hey, Dad. I need your help asking Jessica to prom.
Of course. Love is like the ocean. You have to tread the
Oh,
waters.
Dad. That's not the kind of help I needed. Hey, Jessica. Will you go to prom with me?
Yes.
You don't have to be perfect to be a perfect parent. Thousands of teens in foster care can't wait to share their first with you.
What's up, y'all? It's your boy Jermaine Dolly, Mr. Hello Dolly himself, and guess what? You're tuned in to Tea and Worship with my homies, Mignon and Corey. Keep it locked, y'all.
Hey y'all, it's Candy West, and you're watching Tea and Worship with Mignon and Corey.
It's your boy James Fortune, and you are watching my favorite news show, Tea and Worship, with my sis Mignon and Corey.
Okay. So we heard the numbers. We know we have 25 beds to work with. I think that's how urgent care even came about or was birthed. Tell us about urgent care. What is urgent care? What is urgent care?
I can only speak from personal experience since I have family myself and children that tend to hurt themselves and things of that nature. I am an absolute fan of urgent care, me personally. And that is due to various reasons. But of course, if we're cooking and we accidentally cutting our finger and now we need some stitches, that is something that definitely can go to urgent care. Some urgent cares, particularly the one across the street from us, is equipped to do x-rays. If we feel like, okay, we may have broken an arm or a leg or whatever, you can definitely go to urgent care. Of course, flu-like symptoms, minor flu-like symptoms, you can go to urgent care as well. Urgent care is actually really good in evaluating patients, and if they see they need further emergent treatment, to actually refer them immediately to the emergency department. But that's they do many things. So I think they're great. I personally like them because you don't even have to wait as long as you do here if you come with non-emergent things. So I think they're definitely often underutilized and underappreciated, honestly.
Absolutely. I can. So I'm hearing that anything that's not an emergency, we heard what emergency is today. It's not the intense abdominal pain or pain radiating from your chest or neck, or if it feels like you're having a heart attack, extreme shortness of breath, go to urgent care. Go to urgent care. And you're absolutely right. I didn't have to wait long. I had to go to urgent care last year. Was frightened, didn't want to go to the hospital, but I had to go. And was in and out in an hour. I mean, with everything. So urgent care, that's where we should be going. If it's not an emergency, we should be heading over to urgent care. Is urgent care 24 hours?
There may be some, but most of the ones that I know, they usually close somewhere around 8 or 9 o'clock. So yeah, after that you would have to, and if it's something that needs attention, then of course, by all means, coming to the emergency and don't wait. Certain things like ear pain, for an example, or anybody that had a toothache, although we don't have a dentist and now it's after hours and you can't see anyone, severe pain is an emergency as well. So they should not be
Okay.
underestimated. So ear pain can be horrible. Tooth pain, as we know, although we may not be able to fix your tooth since we don't have a dentist here, but at least we could do something to help with the pain until they seek further care. So.
And you mentioned that you can receive X-rays at urgent care as well.
Yes.
Oh
Yes,
wow! And do
absolutely.
they do labs as well?
I know that they do, maybe like for people experience like urinary tract infection and
Yeah.
things of that nature. They do COVID testing. They do a urine analysis. Now, as far as labs, to be honest with you, I am not quite sure if they actually do labs over there. But I have,
Okay.
like I said, children with sports injuries. I have had, I've been over there plenty of times. So they're great.
And I love it. Yeah, for our parents with our younger children, we can go to urgent care. We don't necessarily have to go to that emergency room. I'm just thinking about those 25 beds, y'all, and getting us
Yes.
in and out, because I know they want to get us in and out, and we want to get in and out. And so that limits our risk of exposure. So urgent care, I'm hearing, is it. But if it's after 8 or 9 and they're closed, go to the emergency. Then you
Yes.
go to the emergency and, bring a reading book. Bring your book to read. Bring something.
Absolutely.
Bring a journal to journal. You'll
Yes.
be there a while. But can you talk about what is happening in the emergency room that it takes so long? So say I do go to the emergency room, it is an emergency, I'm still in this process and it takes a while. What is the process? Can you give us a sneak behind of what's happening and why it still is a process for us to get through emergency room?
I love that question, and I'm so happy to answer that question, because I think often there is a misconception about many things that are actually going on behind the scenes. So let's just start from the beginning. You come in, get checked in. First person that you meet in our emergency department generally is registration, and you will just tell them a general complaint of why you're in the emergency department. Mm-hmm. After that registration person, you would actually see a triage nurse. This is highly trained personnel. They actually have to be a nurse for a certain amount of time. They have to pass a class, so it's not that we have any nurses working here, but you have to have a certain amount of experience in order to be able to work in triage. You will meet your triage nurse, and your triage nurse will assess you, ask you a few questions, medical history, allergies, why are you here, take vital signs, things of that nature. And that already, as a trained triage nurse, will give you a little bit of a picture of what we are concerned with. Mm-hmm. Soon as the patient leaves to have a seat, we actually have a tremendous amount of protocols that we can choose from. So we already start working the patient up prior to them ever having seen the physician. So if you come in for chest pain, the first thing we will do immediately is do an EKG. EKG will tell us right away, I cannot reiterate that again and again, if you're actively having a heart attack, that should show on the EKG. If that's the case, you would immediately be brought back regardless. I mean, we would have to pull somebody out and make things happen, but that would tell us right away if that is, because that again is a life-threatening emergency. If the EKG does not show anything anything concerning at the moment, we do blood work and we do other things, chest x-rays, things of that nature. All of that is being done while we're still waiting to get somebody out to get the next person back. But in the meantime, we have physicians and nurses that continuously will review the results as they come in. So as those results come in, you still may be sitting in our waiting room. We already have a pretty good idea of what's going on with you, because as we all know, blood work can reveal emergencies that we cannot simply see just by looking at you. So if that is the case, then we make sure that we prioritize. So that sometimes causes a delay too for less critical patients, because someone may have come in after you, but now have really critical things that needs attention before anything else, because it could be life or death. So there are many things happening as the patient is waiting. The biggest holdup really in general is not us getting the test done or the results back. It's literally getting that person out of a room so we can pull the next person back. So that often is the biggest delay in everything. It's not us twiddling our thumbs so everything is already, a lot of times by the time a physician comes and see the patient, they already have a pretty good idea of what's going on. So.
Wow, that is it sounds like a major balancing act.
Huge.
And then people are throwing in extra plates and extra oranges. If you're juggling all of this, someone else comes in. So I'm here. I may have an emergency, but someone comes in with a gaping stab wound. That's going to
Oh
take
yeah,
priority, and it's going to push me down that line. So I'm going to have to wait a little longer because we got to get that hemorrhaging stopped. That's what I'm hearing. Like,
absolutely, absolutely. So yes, it's a so also what people don't understand is there only a front door that is visible to the general public. There's also a back door. And so while you wait in the waiting room, you don't see the amount of ambulances that are coming in. So not only do we get traffic through the front door, we also get traffic through the back door that we also need to manage. And so the misconception, I'm glad we spoke on this topic, the misconception often is that when they call 911, the assumption is, oh, I'm coming by ambulance, so I'm going to be bedded immediately in the back and staff will pay attention. Unfortunately, that's not the case. We triage them equally in the back as they come through with the ambulance, and often we will have to send them up front to the triage, and unfortunately they will find themselves in the waiting room with everyone else that may have brought themselves in. So that's also a thing. So I'm glad I can kind of clear maybe some of that misconception up. So just because you come by ambulance does not mean that you will be bedded immediately.
I love it. Thank you, because that's helpful for us. I didn't even think about that. That if I come by ambulance, I'm thinking I'm getting ahead of the line. The triage is determining where I fit as far as priority of emergency.
Correct.
Is that right?
That is absolutely correct. Yes. So the triage is the French word for sorting. So we are sorting through patients based on their emergency. Now, the good news is for people that are going to our lesser acute areas, they don't fall in that category. So the lesser acuities, they really go as to when did they come in. They go by arrival time. The higher critical care area, that goes more by, yes, how acute are you and what do we need to do to make sure, that we save your life and everything will go well. So.
When I was in foster care, I never knew when I would have to move, so I always had my suitcase ready to go. Then one day, I was adopted. My new parents opened their hearts and home to me. My parents cook my favorite breakfast for me every morning. My parents take me on trips I never thought I would go on. They gave me a home and an even better reason to use that suitcase. My parents aren't perfect, but they're perfect for me.
After I come from the emergency care, I've received that treatment. What's the next steps that I should be looking at after that? Because I think there's a drop from there with us sometimes.
Yes, and it's I love this, all this. I have such great passion for this whole subject. I love it. Following up is key. And so this is where often the ball is dropped and patients leave, or they call back a few days later and they're upset with us because they feel like, we didn't do right by them. And that's very unfortunate. It's kind of heartbreaking to me because I'm so invested in this community and in this hospital, so that of course I'm thriving for everyone to receive great care. But we also as adults need to take responsibility for our own selves, and we need to make sure that once we leave here that we follow up. So often, of course, patients come in and the hope is that we fix it immediately. And whatever it is that is bothering them or what caused them to be sick, they want it to be gone, and they want it by the time we hand them the discharge paperwork, they want to be 100%. And that's That's just not possible, as we know. So the key is to understand that the emergency's role, literally we do, I say all because we do a lot, but all we do here is make sure that either if the patient requires stabilization, we stabilize the patient and then the patient will be admitted. Or we rule out, okay, you currently do not have a life-threatening emergency. You do not have a condition that requires admission. You are okay to go home. We are never saying you are 100% well when we hand you the discharge paperwork. What the community needs to understand, though, is that emergency departments will only do tests to rule out a life-threatening emergency. After that, it is important for the patient to follow up with specialties. That's why there are so many specialties in the community, because once they go to that specialist may do additional tests to really get to the bottom of what's really going on. That's what they are trained to do. And so it is very, very important that anytime anybody leaves the emergency department to make sure they follow up with someone.
And so who's doing the following up? Is it the...
We generally give general referrals as to who we would like for you to follow up with. Of course, patients have to understand that anytime anybody sends me anywhere, I check with my insurance first, because for us, there's an in-network and an out-of-network. Us as emergency providers, we don't know which network you belong to or anything, so we generally give a general referral and tell you who we would like for you to follow up with. But ultimately, the patient, it's probably best to call the insurance and say, hey, I need a gastroenterologist or a podiatrist in my area. Can you please tell me who I can go and see? And then schedule an appointment and follow up.
Oh, that's good.
But often it's not the case. And then, you know, people come back several days later and wonder why they're not feeling better. But that's because just that follow-up piece often it goes missing.
So after we finish with the emergency, we get our discharge paper. We need to follow up with that specialist that was referred on that paper. But first, we need to check with our insurance, make sure that we're covered, or who we need to go to that's in our network.
That's just me personally, because yes, knowing, you know, sometimes people follow and may not know how their insurance works, and that can be very devastating when you go to an out-of-network provider and now you receive this ginormous bill and don't even understand as to why. So,
okay,
that's more so from personal experience.
Yes, I understand it. It's such a web, and that's why I love having these conversations, because there's so many layers to the medical profession. And if I'm coming in for an emergency or just trying to get some help, I don't know. I'm just coming. And so I can see how, you know, people could get angry, frustrated, and not come back, or, you know, after being there, I don't want to come back. I don't want to deal with anything, but we do have to follow back up so that we can be where we need to be. So, and make sure that we get that continuity of care. That's the thing, is making sure that doesn't drop off. Make sure that doesn't drop off. So now that we have had that, so we've had our urgent care, we've had our emergency care, emergency department. What about primary care? Primary care, we're gonna kind of wrap up with that. What does that mean? And I know we hear
primary care is the best.
What does it mean? Yes.
Primary care is the best, and it is so necessary. And I just wish that everybody in this community would have a primary care physician. Particularly, we see a lot of hypertension, diabetes. Those are the top two diseases that we see a significant amount of here, especially in DeKalb County. I drew a blank.
Yes.
In DeKalb County. So there's a high number of that. And so what people have to understand is that not everybody is the same. Not everybody functions the same. And so a lot of times it is so important to have a primary care physician, because they will follow you closely. They will put you on some medication, and then you have to follow up in a few months to see if that medication actually works, because what may works for you will not necessarily work for me. And so that continuity of care is so important, because then in 3 months, they will see you again, and then they will check on you and see, oh, okay, well, we may have to add another medication, or we can actually take a medication away and things of that nature. So particularly hypertension, diabetes is such a great balancing act that it requires close follow-up. So I think primary care physicians, just for that fact alone, are absolutely amazing.
Oh, that's so good. And you're absolutely right. We have a high rate of dialysis centers right here in DeKalb. I mean, they're practically on every corner. And so when you mention the hypertension and the diabetes, we know that those are cousins and they really do wreak havoc on our kidneys. And so if we have a primary care physician, they can start to monitor where we are and to make sure we keep those levels down. So it's very important that we do connect with one.
Absolutely. And speaking on that topic, another misconception, which maybe we can help. Sometimes patients, for whatever reason, don't take their medicine for months at a time, And then, of course, one day they're going to start feeling really, really bad, and they come to the emergency department. Rightfully so. They come in with a very concerning high blood pressure, and then often anticipate for us to bring it back down to normal levels. That is one of the biggest misconceptions sometimes. Please hear me when I say that. Sometimes we do not want to bring you to normal levels. And it is not a realistic expectation, because if your body has been compensating for a long time, dealing with this very high blood pressure, dropping it down to normal levels very fast can actually cause more damage than it does good. So sometimes you may come feeling bad, and we give you some of the prescription you should have taken the last 3, 4, 5 months. And we may send you home with a blood pressure that's still outside of the normal range, but that is because we want to prevent from bad things happening to you. Things, if you drop a blood pressure way too fast, people can actually end up having a stroke. So they can have a stroke from the very high blood pressure, but dropping it too fast can also cause a stroke. So sometimes that's why it's important to follow up with primary care, so they can follow them closely and make sure to adjust the medication as needed.
And so even after I come from, I have 2 questions I'm thinking about, but the first one, even after I come from the emergency department or even from urgent care, I should go back and check in with my primary care physician?
Always. Just to make sure that things are trending in the right direction. So always, yes.
Okay. And then going back to what you just said about the medication, I'm thinking about those that sometimes medications can be very high, very expensive. What can we do about that? Are there any options, any programs? If some people are non-compliant, they're just not compliant, but there may be some that just can't afford their medication.
So one great resource that I have found in my professional life as well as my personal life is GoodRx. So people can Google goodrx.com and will be amazed how many discounts you can find on goodrx.com. You can actually kind of almost figure out how much your prescription is going to be prior to even going to the pharmacy. They can see where it is the cheapest. So there's always a comparison list of the medication. And if it's really a medication that patients cannot afford, that definitely needs to be a conversation with the provider, because medications can be changed to sometimes more reasonable costs. So that should definitely be a conversation.
I'm going to write that down. GoodRx. I've seen a commercial before.
Oh,
Yeah.
And it's true. It is absolutely, I always recommend that to my patients. I absolutely love their website. I think it's absolutely fantastic. Yeah.
Oh, wow. Well, thank you for that. I think we'll put that up as a resource so that our people can know, our community can know. And that's everywhere, right? GoodRx is everywhere, right? Okay.
Yes. So they can, and it will tell them how much it is at Sam's, at Publix. When we use that Winn-Dixie, I think even on their website is Winn-Dixie is listed, although we don't have it in this area anymore. But I don't know if Kroger's on there. But yeah, so patient can actually shop around and get a good idea where it is to best purchase their medication for the best price. So,
okay.
Great resource.
Well, Miss Eva, is there anything else you want to share with our audience about urgent care, primary care, or the emergency department? Anything else you want to share with our audience?
I think you've asked me such great questions. I hope I answered all your questions. And I don't have anything else to add, really.
Well, I certainly appreciate you being on the show today. You have given us some sneak peeks of what's happening behind the scene and kind of given us some questions and some understanding of what we need to do and insight on where we need to go and when we need to go. So we heard it here today, guys. Guess what? We're still in the pandemic, but there are
Yes.
options. There are options. So if you have a true emergency, do go. Do go. But you also have urgent care. Urgent care is available. And then always make sure you're connecting with your primary care physician. They are your family doctor. I remember the old school family doctor.
Yes.
That's your family doctor. They know you. They are the ones who actually know you. And you want to get to know them and make sure you keep connecting with them, even in this time. We want to make sure that we
Yes.
stay healthy, you stay healthy. We want to even make sure, guess what, that our system gets a little bit healthy. They need some relief. They need some relief. So as we're in this pandemic, we want to make sure that we're still surviving and thriving. Thank you, Miss Eva, for coming on today and giving us those behind the scenes. You guys, make sure you share this, share this, share this. Let everybody know that we're talking about the behind the scenes of emergency care, urgent care, and primary care. We need everybody to work together as we're trying to reduce our health disparities. So guess what? Have a great week. We hope that you do well. And if you have any emergencies, you know now what to do. So have a good week, and we'll see you later.
Thank you so much.
You had this epiphany based on what your grandmother had done. Saved money for 6 months, paid off debt, slept on the floor, and because of this conversion moment, you literally are sitting on the board of a bank that wouldn't have even given you a loan.
I was a pastor of a church. I was spending so much money dressing like a preacher, driving preacher cars. If I'm spirit-filled, the same Holy Ghost that makes me shout can make me wait. Wait until I can afford a BMW and stop giving money, donating money to big banks, paying them 18% interest for the right to use their credit card to buy something I can't afford. It's a mentality.
Thank you.